Hello, I'm Dr. John Kruse, and today I'm going to be talking about, is it ADHD or is it bipolar disorder? I'll be talking for about 20 minutes. If you have questions while I'm talking, please type them in, and this will be posted on YouTube and Facebook later, so if you have questions later, you can add them then. So I usually start with the takeaway message, and the takeaway for people who don't want to listen to the whole thing. So the takeaway is that if you do have ADHD, you are certainly more likely than someone in the general population to have bipolar disorder. Conversely, if you have bipolar disorder, you are more likely than the general population to have ADHD. So although these two go together, they are clearly distinctly different conditions, and usually some careful examination of the time course of what's going on and particular emphasis on where changes in mood are coming from can be helpful in distinguishing the two. So that's the takeaway. So jumping into it, there have been dozens of different studies tracking how common ADHD and bipolar disorder run together. And although virtually all the studies do show these close associations between the two, and clearly everyone with ADHD doesn't have bipolar, clearly everyone with bipolar doesn't have ADHD. The most recent meta-analysis I found, and this looked at more than more than 2/3 of a million people in more than 18 countries. I think it was more than 24 studies. Their composite studies was about 8% of people with ADHD have bipolar disorder, and that's, by their estimation, only about 2% of the general population have bipolar disorder, so that makes it 4 times as likely. And looking at it from the other direction, of people with bipolar disorder, about 18% of them also fit the criteria for ADHD, which would be, again, about 4 or 5 times higher than the 4 or 5% of people with ADHD in the adult population. However, the studies they looked at showed a range of from 2 to 40% of people who have bipolar disorder having ADHD. So that's an incredibly broad range. There's a lot of problems with how we define these different conditions in different studies. I'm not going to go into that. I'll just acknowledge there is a lot of slop. On one of the popular ADD websites, I heard claims that as many as 2/3 of people with bipolar disorder have ADHD, and as many as 20% of people with ADHD have bipolar disorder. I would say very few studies have come up with rates that are that high, but I'll just leave it. There is an association, it's clear. Couple other things we know about the association: if you have either condition, if a family member has bipolar disorder, other family members have increased rates of bipolarity and of ADHD compared to the general population. And similarly, if you have someone with ADHD in your family, blood relatives are more likely to have both ADHD and bipolar disorder. So there do seem to be some common genetic predispositions to both. So that's the one other thing that comes out from the associations. 2 other things. One is if you have both conditions together, not surprisingly, the severity of symptoms and degree of impairment seem to be higher, and also of people who have both conditions tend to have about a 4-year earlier onset of their bipolarity than the general bipolar population. So those are fairly robust findings from different studies. So jumping over to what is bipolar disorder? I mean, it's what we used to call manic depression. And bipolar means 2 poles, so people swing from manic states to depressed states down here. And I emphasize that even though we call it bipolar disorder, it's a triphasic condition. And by that I mean the standard definition is that you are not always in mania or depression, that you also have periods of what we call euthymia, or a neutral state, and that the depression down or the mania up are deviations from it. So this is a condition that's characterized by episodes of either mania or depression imposed on a background of at least sometime you're in a euthymic state. And that doesn't mean, and there's good studies that show for bipolar people, the more episodes of depression you have, there are more elements of depression that creep into the euthymic state. But I'll leave it at that. Currently, we define bipolar 1 disorder as people who have full-blown episodes of depression that last at least 2 weeks long at a time, and episodes of full-blown mania, which last at least a week at a time. We also have bipolar 2, which is considered a less severe. Some people think it may be categorically different, not just less severe. But the official definition is defined basically as a less severe case. So the mania does not have to be as impairing in terms of function, and it only needs to be going on for at least 4 days at a time and doesn't have to have as many of the symptoms. And we also have bipolar 3 condition, which is defined as mania that's only been induced by medication states. There's also cyclothymia, which is a milder form. And there's been some proposal that maybe rather than trying to parse into 1, 2, 3, and 14 different bipolar conditions, we should just be asking for anyone who's presenting with depression, what is the degree of bipolarity in that person's condition, and acknowledging there are some people with pure depression with not an element of any manic history or hypomania. So it's even though some of the ADD, there can be overlap between depressive states and ADD symptoms, and particularly inattentive, poor concentration, distracted, low motivation can be present in both conditions. Usually it's not hard to differentiate depression from ADHD. Again, they can occur together, but the primary aspect of depression is low mood, and that's usually so characteristically the presenting symptom that I would argue seldom have I seen people who've real diagnosis is only ADHD who get confused with only identifying depression. It certainly happens, and the other way around is even less likely, that someone who has real depression is being falsely diagnosed as this is just ADHD. That's not very likely at all. But with mania, there's often a lot of confusion, and part of it is, so what is a manic state? So our official definition is that you are in either high spirits or irritability or grandiosity, so full of yourself, overinflated opinion, actions of yourself for most of the time for at least a week, and that you have at least 3 of 6 following sets of symptoms. And every one of these 6 states is a classic, particularly hyperactive ADHD state. So number 1 is talking more, so talking excessively. Classic for mania. Again, with mania, it's a departure from the baseline, but many people with ADHD are overtalkers, talk rapidly, hyperactive talking. Number 2, racing thoughts. Again, with mania, that's by definition a deviation from that person's baseline, but racing thoughts are classic presentation for people with ADHD. Number 3, distractibility. So when someone's in a manic state, again, they are more distractible, paying attention to different things, more easily pulled off track than in their normal euthymic or depressed states. But again, with ADHD, that can be a constant, ongoing feature of the ADHD. Restlessness, so either just physical hyperactivity, greater motor action, and or more energy excessively focused in a goal-directed direction. So an example of that, I had a patient years ago who decided that San Francisco didn't have an old car museum, so in their manic state, they had no ADHD, this is just mania. They decided to take their life savings and buy a bunch of old model cars they could buy as an individual, and rent a large building and move all these cars to it and have some of the cars detailed, and they would open this museum, which would go wonderfully. So they expended huge amounts of energy in a goal-directed way, again, that can overlap with looking like ADHD in terms of someone who's hyper-focused. Again, usually with mania, it's going on longer, it's more dysfunctional, although clearly, and we talked about hyper-focusing and flow a few weeks ago, that can also be dysfunctional at times, but usually not to the extent that someone can carry it to in a manic state. So I think I've only gotten through 4 of the symptoms: excessive talking, racing thoughts, distractibility, physical restlessness, risk-taking. So someone in a manic state, and there's sort of a triad of sexual acting out, financially acting out, spending money you don't have, or traveling abruptly to places that you hadn't really put much thought into, and you just get on a plane or get on the bus and show up in a place that sounds cool or interesting without having thought of where you're going to stay when you go there. So risk-taking, though, is also a trait with ADHD we see. And then number 6 is decreased sleep. And it's not just decreased sleep, it's decreased need for sleep. And I'll be getting to that distinction in a few moments. So again, all of those look like ADHD as well as being characteristics for mania. So how do we start differentiating someone who's presenting with all this cluster of symptoms? So the number one biggest clue to what's going on, and again, you can have both conditions, is finding out what the time course is. If someone's presenting like this, finding out, is this how you show up every day at work? Is this how you've been for the last 3 years at school? Is this a chronic ongoing condition, or is this an episode that's different from your baseline that you're presenting with? And again, although the minimum period for a manic episode is a week, they can go on for many weeks or months at a time, and usually, and often dramatically and destructively, because people are both impulsive and judgment is impaired, and it's easier to blow up your life with mania than it is with depression, because you're just full of ideas and full of energy and putting it in directions that aren't helpful to you, rather than depression can also be destructive, but tends to be more passive state. Anyway, time course. So one is the longevity of the symptoms. So where that can get confusing is someone with ADHD may have distractibility as a constant feature of their state, but in different environments. If they are skateboarding, they may be completely focused, and if you're only seeing them in that environment, you may, and then you see them in a different environment where they're in the classroom where they're distracted, you may not appreciate that the distractedness is a lifelong, ongoing symptom for them. It's just, so in addition to just the longevity versus the episodic nature with bipolar disorder, with mania, also the age of onset's important. So the older definitions of ADHD required that symptoms start before the age of 5. The more recent revisions only required that symptoms start for 12. But what we know is that most people, if you can, really go back and examine or get good personal history or good collaborative history, most kids with ADHD, or most adults who have it, did have symptoms starting pretty early in childhood. They may have been smart enough, there might have been few enough demands that they could slide by or get through, or it didn't disrupt their world. But again, with ADHD, symptoms classically start fairly early in childhood, and although some individuals do seem to outgrow it by the end of late adolescence, early adulthood, we know the majority, and I use figures of about 2/3 of kids with ADHD do go on to have it in their adult lives. Bipolar disorder, classically, first manic or severe depressive episodes classically start in late adolescence or very early adulthood. It can show up a little later. So again, that time course is a little different. It's a more delayed onset. Clearly, and this had been a controversial idea 20 years ago, it's more widely accepted that there are kids who have manic episodes when they are younger. So most of what I'll be talking about and have been talking about is in adulthood, where it is easier to make the distinction. You have more time, You can ask better questions. You can have your subjects more articulate or introspective about their mood and thinking states. So there are some kids with early onset in childhood of bipolar disorder, and again, of individuals who wind up having both conditions. The average is about 4 years younger for presentation of first manic episodes. So why it's so important to catch the time course, and in my book I mentioned this anecdote, and I'll go into it in some detail. Very often in our modern, at least in America, medical world, mental health world, there's a very separate entity that the inpatient experience is unconnected and disconnected from what goes on treatment beforehand. So I had a patient in her mid-40s at this time who I'd seen her for most of a decade. Clearly hyperactive type ADHD. She was in a small group format. She would always, that I first saw her, nonstop talking, interrupting others, kind of rude and brusque, kind of loud, kind of querulous and argumentative. But this was her presentation every day, good mood, bad mood, over the course of group, individual, how she described being at work. I did talk to family members. This is how she had been every day of her life for up to 40 years. She was hospitalized at the age of 40. I won't go into too much detail. She had gone out of state for several years, came back to San Francisco unknown to me, and she was in a crisis. So there was more than just severe ADHD going on, but they diagnosed her with as being manic rather than this is her severe baseline ADHD. She told them that she had ADHD. She explained what her symptoms were. Eventually, after a week in the hospital, when the anti-manic treatment wasn't doing much good, she called me, the patient called me, and I did call the hospital to tell them that this woman has never had a manic episode. They chose to ignore that information and kept giving her heavily sedating mood stabilizers, and eventually sedated her enough that they were comfortable her manic episode, and anyone, manic or not, if you give them enough sedating medications, will be sedated. They discharged her after 2 weeks or so in the hospital. The day after she was discharged, feeling that her problems hadn't been addressed and she had been severely misunderstood and maltreated, jumped off the Golden Gate Bridge. So there can be fatal consequences to not bothering to take an accurate time course and trying to separate out what is mania and what is ADHD. Other important issues. So of all those symptoms, a lot of them, probably in the years ahead, we will have more quantitative ways to measure how fast someone's talking and whether they are hyperactive in their movements. Right now, those are largely clinical judgments. So often we gravitate towards, of those 6 elements, the one that's easiest to quantitate is sleep. If someone's sleeping only 2 hours now and their baseline was 7 or 8, that's clearly a difference. So there's, I'd say, I don't know if it's undue, but an excessive emphasis on the sleep as being the most objective quantitative measure there. But I think it's misused so that many practitioners that I'm aware of define anyone who's been up all night in an agitated state as meaning that has to be mania. And again, that could be mania, but one is, I've seen people with a pure anxiety disorder. That's all they had, and they were having panic attacks. They couldn't fall asleep because of their panic attacks. That's not mania. So I've seen that be misdiagnosed as mania. I've seen people with ADHD who, reported to their practitioner that they had been up all night, playing video games or doing their last-minute projects, and that being misconstrued as a sign of mania because they were up all night. So one difference, or one critical piece, is it's not just decreased sleep that's characteristic of mania, it's decreased need for sleep. So usually the people with an anxiety disorder or the people with ADHD or someone who's stayed up all night for a different reason will be really tired when that bout of activity or bout of anxiety is over, and they will crash. Whereas with someone in a manic state, they will persist for days, weeks at a time. Eventually their body will be fatigued, but they're not feeling tired from being awake so much and being so sleep deprived. And the third issue I'll get to is mood swings. And I hate the term, but I think it's used confusingly. We don't have precise definition for it. And it's used so often to anyone having an emotion is told they're having a mood swing. So by nature, what is an emotion? Each moment, or why do we have emotions? Why are they there? We're bombarded by thousands of pieces of information. Just looking at all the books on my bookshelf and the different colors and shapes and the different sensory information that's pressure on my body from the chair and my feet on the floor, my fingers resting on the desk, and there's the sound of my voice, the sound of birds outside, the sound of tinnitus. I mean, we're bombarded by all sorts of sensory information, and not all of it's important. The role of emotions is to make some of that information saying, this is really important, you have to pay attention to it. So by definition, emotions are a deviation from the baseline. They're a more intense state because they're designed to say, this is important, look at this is either dangerous or disgusting, don't eat it, or threat, don't go there, or unfair, evoking anger. So by definition, emotions are intense. They are a change from the baseline, and they are non-cognitive. I mean, they are in emotional state. They are non-rational thinking, so people have harder times using words often to express them or understand what's going on. So mood swing is not characteristic or meaningful way to diagnose bipolar disorder. Again, and in fact, in some ways is antithetical to, not antithetical, but a mood, a manic state, a hypomanic state is a prolonged episode lasting not just minutes, not just hours, but days at a time in a prevailing certain state. That almost is in opposition to what we use the term mood swing, which means volatile moods in a given day. Now, the irritability. Now, people in manic states often do have mood swings. They often switch from happy to sad to irritable in a given moment. But again, that isn't, a mood swing isn't the same thing as mania. That's what I'm getting at. So the other really important distinction, and I'm dichotomizing in a way that lots of episodes we can't classify completely purely, but in a manic or depressive mood state, part of it should feel, or the origin of the emotional change in emotional state is coming from inside. It's endogenous. It's not purely reactive. It's not just overreacting to your environment. So now, when you are in an irritable state, you may overreact to your environment, but the mood, it's at least some part of the mood has to feel that, out of the blue, I'm feeling sad today, and that sadness may pervade a lot of different aspects of my life, or that anger may pervade aspects of my life. But it's not just that I'm seeing this, which normally would cause me to be angry, and I'm angry at it, or finding angry things. So, and people with ADHD, particularly hyperactive forms or combined types of ADHD, we know emotional volatility, lability is a part of it, that they are more likely to have the emotions come up quickly, come up strongly, and to react to what's going on in front of them. But they're also, if someone spilled milk at them in the cafeteria, they blow up and they're angry, and they may be angry for the rest of the lunch period, but if their favorite teacher flirts with them on the way to the hallway, then they may be, right away in a different state. So people with ADHD have greater ease, usually in switching out of it, whereas someone in a manic state, if they're feeling grandiose, they may be dismissive of both the people spilling milk on them or thinking that everyone in the hallway is flirting with them. So they are taking their mood and imposing it on the situations rather than having the situation impose a mood on them. That's maybe I'm over talking it, so that's what I'll say there. So again, you can have mania, you can have ADHD, together, but they should usually be distinguishable both by the course of history and the symptoms themselves. If you look closely enough at them, I think I'm going to stop. Well, I'll throw in, I'll get back to one of the other things that really was jarring to me in an article I read online at a prominent ADHD site, claimed that in our modern day, because ADHD is more common than bipolar disorder, so that's fact-based, that's every epidemiologic study would agree with that. They then went on to claim that most of the time, that means doctors are seeing ADHD more than they're seeing bipolar disorder. Therefore, the problem is, doctors are familiar with ADHD, they're less familiar with bipolar, so they're missing bipolar disease and attributing it to ADHD. That may be true in the child world, but certainly in the adult psychiatry world, that is completely inconsistent with what I see. And what I see is multitudes of patients getting overdiagnosed, being told they have bipolar disorders when they're either not there at all or minimally there, and lots of adults still in a well-educated, mental health oriented part of the world having ADHD and having had it their whole lifetime and that being missed. So I don't see as common a problem. So what I see is ADHD being missed and falsely diagnosed as bipolar disorder, not the reverse situation, which this person claimed. And I had an example just from yesterday, so I'll show it. Patient went into a neurologist, patient of mine, for back pain, head pain, problems from a motor vehicle accident. Told the doctor, this is a 50-year-old guy, I have ADHD. The neurologist said, well, did you graduate from high school? And this guy, although of above average intelligence, said, yes, barely. The doctor said, well, he couldn't possibly have ADHD. And then on his evaluation for the patient, mentioned the back problem, back pain, head pain, other symptoms related to the accident. But the number one neurologic symptom they put on was mild cognitive impairment, which is a precursor to dementia. And their evidence for mild cognitive impairment was that the patient brought in notes to the session to keep themselves organized, that they went off track when they were describing things, that they were disorganized in presenting their own history. So this patient told the doctor they had ADHD, was told they couldn't possibly have it, and then a host of classic ADHD symptoms were mischaracterized by this treating physician. So that's all I'll say today. I'm not seeing any questions right now, so I will end and see you next week. I'm going to be talking about when will my meds start working, so a more pharmacologically oriented talk. Stay healthy, stay happy, and I'll see you next week.